Okay. Hello, good morning. My name is Jamie, and I'm doing a rotation with Dr. Bernard on neurology for a month. And today my presentation will be on a topic that I encountered very frequently during my time here, and that is mild traumatic brain injury. Okay. Cool. Right. In terms of housekeeping, today I'd like to start off my presentation by describing a case that I encountered personally, and then use that to kickstart a discussion on what mild traumatic brain injury entails, how you would approach someone with this condition in the outpatient neurology clinic. And I'd like to bring everything back to the case that we discussed in the beginning. Okay, so starting off with the case, I encountered a 60-year-old right-handed gentleman presenting to our services to follow up on his motor vehicle accident that occurred 1 month ago, prior to the appointment. Some more details on the accident. The patient was driving a rental car. He had 3 passengers in the car, but he was rear-ended from behind, and he ended up hitting the car in front of him. The impact caused multiple hyperextension and flexion of his head, as well as head trauma from hitting his head on the steering wheel. The patient sustained minor lacerations from this. The patient mentioned that he lost consciousness on impact for a few seconds and experienced immediate headache, nausea, and disorientation. According to his passengers, he was asking the same question multiple times. On presenting to the appointment, his chief complaint included a constellation of symptoms, including bilateral frontal headache, blurry vision, dizziness, nausea, unsteadiness, difficulty falling asleep, low motivation, short-term memory loss, decreased concentration, and being very irritable. We looked through his health records that he brought. His initial EMT evaluation was noted to, his GCS was noted to be 14 out of 15. His CT head done at the emergency department showed no abnormalities. We examined the patient. His blood pressure was slightly on the high side. His pulse was on the low side. He was oriented, but a neurological examination revealed no significant abnormalities aside from difficulties with tandem gait. His speech was normal. We saw that he answered questions appropriately, but the patient noted that he was slower than his usual self. And overall, our impression was no focal neurological loss on examination. So given the constellation of these symptoms and their acute nature, some differentials that pop up to mind include stroke, TIA, hematoma, seizures, but his history of sustaining head trauma from a motor vehicle accident, the mechanism of injury, as well as the unique combination of symptoms really point towards traumatic brain injury. So before we move forwards, I'd like to take a moment for everyone to think about the definition of traumatic brain injury and how it differs from a simple head injury. So I'll pause for a few seconds so everyone can have a think. The reason why I did that, asked that question, is because I thought traumatic brain injury and head injuries were the same thing, but I was wrong. So the currently traumatic brain injury is defined as an alteration in brain function or other evidence of brain pathology caused by an external force. And I'll break everything down by bits. Let's start with the first part, alteration in brain function. In order for someone to have alteration in brain function, the following clinical features need to be present. Firstly, any period of loss of consciousness or any loss of memory immediately before or after the accident, or any alteration in mental state at the time of the accident. So our patient had loss of consciousness and alteration in mental state. And the second part, other evidence of brain pathology, this refers to evidence on imaging or lab work. So without any of these features, alteration in brain function or evidence of brain pathology, you have just a head injury and not a traumatic brain injury. What makes a traumatic brain injury mild? It's mild if the severity of deficits described above do not lead to an initial GCS of less than 13. Another term that we need to clarify on is concussion. Concussion is used quite synonymously with mild traumatic brain injury. But there is a definition for it, but context-wise, it's used to describe the signs and symptoms that patients complain of following traumatic brain injury. Moving on to epidemiology, who gets traumatic brain injuries? Firstly, generally, older adults are at higher risk of sustaining traumatic brain injuries. Males across all age groups are more likely to sustain traumatic brain injuries compared to females. Leading causes include falls, that is the #1 cause of traumatic brain injuries, and these tend to be more common among older adults. Another major cause is motor vehicle accidents, which tend to be more common among younger adults. We also have direct blunt trauma caused by sports injuries, especially contact sports such as American football or ice hockey. And we also have blast injuries, which are more common amongst military personnel who are involved in conflict. So how does traumatic brain injury work in terms of pathophysiology? It's divided into two types. So there's firstly primary brain injury, and secondary brain injury, which I'll discuss in the next slide. Primary brain injury occurs at the time of the trauma. It can occur through multiple ways. Firstly, direct impact injury from something, the head striking an object or an object striking the head. Acceleration, deceleration injury, where the brain really bounces inside the skull and hits the skull. Blast injury caused by shock waves shaking the brain inside the cranium. And all of these processes are quite different, but what they have in common is that they cause diffuse axonal injuries, i.e. shearing of the white matter tract, contusions, which basically mean bruising of the brain as it bumps onto the skull, and hematomas, which we are very familiar with. And overall, all of these injuries can basically refer to So all of these mechanisms of injury is primary brain injury. Moving on to secondary brain injury. So secondary brain injury is slightly different to primary brain injury in that although it starts at the time of the accident, it goes on for hours and days, and it's caused by molecular injury mechanisms that are initiated at the time of the trauma. Such mechanisms include release of excitatory neurotransmitters such as glutamate or free radicals that damage the neurons. Inflammatory processes that were intended to help with regeneration and repair, but end up doing more damage. Secondary ischemia, for example, from vasospasm or focal occlusions. And all of these combined cause neuronal cell death, cerebral edema, and raised ICP, and overall they end up causing more damage than they already have. Now that we've discussed how traumatic brain injury works, how does someone with mild traumatic brain injury present in an acute setting? The hallmark symptoms are confusion and amnesia, could be retrograde, anterograde, with or without preceding loss of consciousness. It's quite important to note that you don't need to have loss of consciousness for someone to have a mild traumatic brain injury. So the symptoms, it's quite a lot of text on the slide, but generally speaking, the symptoms are divided into three main categories. Firstly, physical symptoms such as headaches, sensory symptoms such as dizziness or visual disturbances, and neuropsychiatric symptoms such as mood or cognitive disturbances. And these symptoms tend to come on at different stages. Immediately after the trauma or minutes to hours following, patients commonly complain of headaches, dizziness, lack of awareness, nausea, vomiting. From a few hours to days after the trauma, they start complaining of mood and cognitive disturbances, sensitivity to light and noise, sleep disturbance, and post-traumatic seizures. In terms of signs, the most important takeaway is that patients who have a mild traumatic brain injury do not necessarily have observable signs. You could observe in coordination, they're stumbling and they struggle with tandem gait, but this is not necessary. There is actually a term that's used to refer to the constellation of symptoms that patients experience after a traumatic brain injury, and that is called post-concussion syndrome. Approximately 30 to 80% of patients with mild traumatic brain injury will experience some symptoms of post-concussion syndrome. The most common symptoms include headaches, and it's quite interesting that these headaches, they have features that resemble primary headaches. The most common ones are migraine-like headaches and tension-type-like headaches. And notice how we say like instead of saying migraines or tension-type headaches. Another symptom they complain of include lightheadedness or true vertigo. Could be caused by concussion in the labyrinth or BPPV. Sleep disturbance, most commonly manifesting as excessive daytime somnolence, increased need for sleep, and insomnia. So as psychological and cognitive symptoms, which over 50% of patients experience, and these include personality change, irritability, like our patient, anxiety, depression, intolerance to noise, and these symptoms can actually develop into fulfilling criteria for a formal psychiatric diagnoses. For example, panic disorder, anxiety, PTSD. I've seen some patients who have actually developed PTSD from their motor vehicle accident and concussion. Other symptoms include memory impairment and concentration, which were also present in our patient. Now let's look at the prognosis of mild traumatic brain injury. What's the natural course of the condition? So patients who have post-concussion syndrome, the symptoms tend to be the worst in the first 7 to 10 days after the trauma, the accident. The symptoms should gradually improve. By 1 month, it should already be on the course to recovery, and by 3 months, the vast majority of patients have recovered. But in some patients, they complain of persistent symptoms past 3 months since the trauma, and we would describe that as persistent post-concussion syndrome. What puts someone at risk of persistent post-concussion syndrome? I believe there was a review done by Carroll et al. That looked at various risk factors. The most consistent risk factor, the strongest one that they identified, was ongoing litigation or compensation issues. There were few other risk factors shown here, but they have varying evidence supporting them. Can go through a few. Got prior head injuries, other neurological psychiatric diseases, life stressors, older age, repeated concussions, which means that person has sustained a concussion, they're still symptomatic, they haven't recovered from it, but during that period they sustain another concussion. We see this quite commonly in athletes, and that actually really makes it difficult for them to recover from that second concussion, and it increases their risk of concussions in the future. So again, repeated concussions were identified as a risk factor for persistent symptoms of post-concussion syndrome. We also have female sex, but the evidence is inconsistent for this risk factor on determining whether patients will suffer from persistent symptoms. When someone presents with a mild traumatic brain injury, how do we approach them at the outpatient neurology clinic setting? The key principle is to adopt a symptom-oriented approach, i.e., you focus on the symptoms that the patient is complaining of. If the patient presents with predominantly visual symptoms, then you would refer them to ophthalmology for evaluation. If they present predominantly with psychiatric symptoms, cognitive disturbance, you would consider doing neuropsychological testing or referring to psychiatry for proper evaluation. If the patient complains of disabling symptoms, or maybe they didn't have any initial imaging done, because you have to remember that not everyone who sustains a head injury gets CT head in the emergency room. For these patients, we could consider doing an MRI brain to rule out serious pathology, alternative explanations for their symptoms, or even to catch the subtle differences that CT head may not have picked up in the initial evaluation. One thing to note that currently the evidence suggests that EEG is not routinely recommended. I think from what I recall, it's because it will be abnormal anyway and it will resolve in its own time. It doesn't really confer much diagnostic benefit. Moving on to treatment, mild traumatic brain injury. The principle is the same as evaluation. You adopt a symptom-oriented approach. If someone has headaches, then you would, and you have identified what type of primary headache their headache resembles, and you treat as per the primary headache protocol. The initial first-line management is to give them a simple analgesic such as ibuprofen or acetaminophen, and then give them a preventative as per the primary headache protocol. If they have migraine-like headaches, then you give them propranolol or topiramate. The second symptom that you could tailor your approach to, if they have sleep-wake disorders, then you could consider doing a sleep study, and also giving them wakefulness promoting agents such as modafinil or armodafinil, which are first line currently. Someone has cognitive complaints. I believe the current evidence says that there isn't a recommended approach. I believe some people a study has tried doing cognitive rehabilitation, but the evidence was a bit murky on the benefit. Someone presents with psychological complaints, you could consider psychotherapy such as CBT, and even consider prescribing antidepressants or anxiolytics as necessary. And the other key principle to treating mild traumatic brain injury is providing reassurance to the patient, telling them that yes, your symptoms are valid, it is part of a recognized clinical syndrome, and that it will improve. And just patient education is important, and can keep calling them in for follow-ups to check, monitor for new or worsening symptoms. Okay. Something that I wanted to mention about mild traumatic brain injuries was what the guidelines are on when patients can return to work or when athletes can return to play. Currently, there is no strict period of physical or cognitive test that's recommended for returning to work. It's the common recommendation is for people to take at least 24 hours of physical or cognitive rest. However, the evidence isn't clear on that. So what would be prudent is to tell the patient to return to work, gradually return to work as tolerated, and as their symptoms permit them. Another prudent guidance for the general population is to avoid activities that may cause another concussion, because that can increase your risk of getting for future concussions, and the prognosis is not as good. Specifically for athletes, the stakes are high because if they return to play or practice prematurely while they're still recovering from a current concussion, that would increase their risk of subsequent concussions and cumulative brain injury. And over time, this can lead to neurodegenerative processes as well as dementia. So there are guidelines specifically for athletes on how they can gradually return to play. I believe the 2012 consensus statement on concussion in sport recommended 6-day gradual return to play, where the athlete would gradually increase the amount of activity they do every day over 6 days, and just tailor it, really respond to how their symptoms resolve or progress. But overall, the general point of these guidelines is that if an athlete is suspected or diagnosed with having a mild traumatic brain injury, then you would remove them from play, from games or practice, and they would have to stay off until their symptoms resolve and they're off medications. Now, I understand we've discussed quite a lot about mild traumatic brain injuries, so I'd like to bring it back to the case that I presented in the beginning of my presentation. Just as a reminder, we had a 60-year-old right-handed gentleman with a history of a motor vehicle accident occurring 1 month ago. At the time of trauma, he lost consciousness and was disorientated. Now he's complaining of a constellation of symptoms: headaches, dizziness, blurry vision, memory problems, concentration difficulties, sleep disturbance, and irritability. His GCS was 14, his CT head showed no abnormalities, examination, no significant abnormalities. So our assessment was that the patient was suffering from post-concussion syndrome, from mild traumatic brain injury. And firstly, our plan was to consider performing an MRI brain with contrast to rule out serious causes or detect subtle damages that the CT may not have picked up. The patient may have developed a hematoma that wasn't present in the initial evaluation, so we wanted to check for that. We're now adopting a symptom-oriented approach. For the patient's headaches, we recommended Tylenol. For his visual disturbance and dizziness, vestibular physiotherapy. For sleep disturbance, we gave him the sleep hygiene recommendation sheet and would put the plan as considering sleep study or MSLT. For his cognitive disturbance, we reassured the patient to expect improvement over the months. If he doesn't improve on the next follow-up, we said we would consider neuropsychological testing. For his mood disturbance, consider CBT. And overall, we reassured the patient that these symptoms are normal for what he has gone through and that they will improve, and we recommended gradual return to work as tolerated. So the take-home messages from today's presentation is that the definition of traumatic brain injury, it's defined by an alteration in brain function or evidence of brain pathology caused by an external force. Without the alteration in brain function or brain pathology, you just have a head injury. The second point is that the prognosis for mild traumatic brain injury is good. The vast majority of patients should have recovered by 3 months, but some people can have persistent symptoms, in which case they have persistent post-concussion syndrome. And lastly, the evaluation and treatment for mild traumatic injury is symptom-oriented. And these were the resources that I referred to. And thank you so much for your time and attention.